Stage 1 begins with the resting uterus. At this point, the cervix remains thick and entirely closed, acting as a structural barricade. This diagram illustrates fundal dominance. Upper myometrial muscles contract in a synchronized downward wave. Pressing against lower tissue, the internal cervix softens and defaces, its collagen matrix stretching laterally. Downward pressure expands the opening to 6 centimeters, measuring early labor progress precisely. Active labor requires a measurable, sustained increase in the amplitude and frequency of contractions. This amplified force drives the cervix to its maximum diameter of 10 centimeters. The cervical tissue completely retracts out of the downward path, leaving a clear route into the birth canal. Externally, this intense internal pressure is often accompanied by clear clinical signs, like the rupturing of the amniotic sac. Stage 1 concludes once the anatomical barrier between fetus and exterior environment is structurally dismantled. With the barrier eliminated, the body transitions to the expulsion phase. 2 distinct physical forces now combine to drive fetal descent: the continuing myometrial contractions of the uterus working in tandem with maternal intra-abdominal pressure. Descent faces severe architectural constraints. A pelvic wireframe reveals narrow, asymmetrical choke points. To clear these, the fetus executes cardinal movements. The skull graphic pivots sharply past the first bony obstruction, its widest diameter aligning perfectly with the widest pelvic axis at each stage. Once the skull navigates the final curve of the pelvic outlet, remaining mechanical forces push the shoulders and torso clear, completing the delivery. In Stage 2, the fetal skull must continuously rotate to navigate the complex, shifting geometry of the maternal architecture. Fetal expulsion empties the uterine cavity, but the biological process requires one final mechanical step. The empty uterus reacts to the sudden loss of volume. The thick, muscular walls rapidly fold inward, shrinking the overall surface area of the organ. Because the anchored placenta does not shrink, this sudden decrease in maternal surface area creates an intense shearing force between the two structures. This force physically shears the placenta from the uterine wall, allowing it to finally detach. Detachment introduces an immediate physiological requirement: hemostasis. The body must rapidly halt blood flow from the severed vascular connections at the placental attachment site. This diagram shows the mechanism of hemostasis in action. The rapidly shrinking uterine muscle fibers act as natural ligatures, physically clamping down to pinch closed the maternal blood vessels. While Stage 3 is the shortest phase of parturition, its role in preventing postpartum hemorrhage makes it the most critical for maternal survival. Because these biomechanical forces operate internally, medical professionals rely on external instrumentation to monitor their progression and detect potential failure points. The first priority is confirming true labor by distinguishing between irregular spasms and functional dilating contractions. A device called a tocodynamometer translates physical uterine pressure into trackable data. This comparison shows the jagged output of false labor against the escalating, symmetrical wave patterns generated by functional contractions. Fetal heart rate monitoring is the primary indicator of how the fetus tolerates descent pressure. Physiological distress appears directly in this data. Notice the abnormal deceleration. The fetal heart rate line dangerously dips precisely when the uterine contraction wave hits its peak pressure. Medical teams scan for warning signs: irregular contraction patterns, prolonged timelines without dilation, and heavy bleeding disrupting hemostasis. Delaying medical evaluation can be dangerous, particularly when active labor progresses faster than anticipated. Clinical monitoring tools serve as essential translators. By turning invisible structural changes into actionable data, they ensure the biological safety of both patients. The entire biomechanical timeline of parturition reveals a strict sequence of events, spanning from the first functional contraction to the achievement of hemostasis. Forceful dilation dismantles the cervical barrier. Precise cardinal movements navigate the pelvis. Finally, a rapid reduction in uterine volume forces placental detachment. To manage this timeline safely, clinical protocols rely on the 5-minute rule. When contraction spikes occur at regular, exact 5-minute intervals, the threshold for hospital admission has been reached. Crossing this timing threshold signifies the body has transitioned from latent preparation into active biomechanical execution. Recognizing these physiological milestones empowers patients to track their own progression and seek medical support at the correct moment. The physics of childbirth reveal a rigorous, deeply observable biomechanical architecture.